Good morning and welcome to one of our first breakout sessions today, promoting prevention across the life course from first cell to last breath, which has been kindly supported by Sanofi UK, so many thanks. I'm really happy to be joined by an expert panel of speakers today, so I'll keep my introductions very short. We've seen during COVID-19 really starkly how important it is for us to address health inequalities across the life course. And for those of you who've listened in on Michael Marmot's presentation this morning, we'll be leading straight on from there, really. It's also shown us how important prevention is in public health, regardless of age. And actually, I think we've seen firsthand the cost of not preventing across the life course. It's shown us that the way we're doing things isn't really sustainable. Some work we published earlier this year found that actually if we continue going as we are going at the moment and in the context of an ageing society, over the next 20 years, we're likely to see at least an increase of around 17% in life spent with preventable diseases. And if we just look at how health systems across the world have dealt over COVID-19, how overstretched they've been, we see that absolutely we need to be moving upstream and preventing some of these conditions from developing in the first place. There's a clear health case for promoting prevention across the life course. You know, we all want to be living healthier lives. There's clearly a clear social and moral case, but there's also a really, really important economic case. And as countries across the world are increasingly relying on older workers, older spenders, older volunteers, older carers, we absolutely need to be making sure that we're not just living longer, but also healthier lives. So without much further ado, I'm really happy to be introducing our panel of speakers today to be sort of looking through some of these questions in more detail. You'll see there's a Q&A feature on the right-hand side of your screen as well. We might be a little bit pressed for time, but if we do have time for any questions at the end, we'll be bringing them in. And if not, I'll be emailing questions to speakers afterwards and we'll be getting back in touch with you that way. So today we'll have Lord Geoffrey Filkin joining us, talking a little bit around, you know, how as a country we can sort of build back from this and think about a sort of healthier nation. We have Francesca Colombo from the OECD joining us, who'll be talking about how as countries internationally we can work together to promote prevention beyond the pandemic. Then we'll be hearing from Prof Les Mayhew, one of our colleagues here at ILC, about the role of big data, at a case study looking at diabetes in particular. And then Debbie Woods from Sanofi will be talking us through a bit how we can look beyond the pandemic, how we need to adapt looking forward. Lord Geoffrey Filkin, thanks so much for joining us today. For those of you who don't know Jeff is a very long friend of ILC. He's worked as a chief executive, a government minister, an experienced chair and has led innovations in all sectors as a chair, a board member and a founder of charities, including the Centre for Aging Better, one of our partners here at ILC. Most recently, he's led the development of the All-Party Parliamentary Group on Longevity, which has published its report again earlier this year on the health of the nation, a strategy. So Jeff, from everything we've learned from COVID so far, where do you feel we need to be going to make sure that we're actually delivering the healthier nation that you're aiming for in the report?
Thank you, Lily, and hello, everyone. I'll go quite fast because I think I'm meant to get through it in 10 minutes, aren't I? Lily will turn my camera off if I go over, so I can't slow down too much. First of all, why does it matter? I'm going to go quickly on this, which is the first slide, because in a sense, you all know this already. In essence, you know that we're living longer. We're living 10 years longer on average than our parents' generation, but we're not living as long in good health. And so that obviously means that we're living longer in ill health. And for many people, that is widespread and it is very serious. It's serious because although you still manage to cope if you're ill, it degrades your well-being and it increases the risk that you'll fall out of the labour market. And that, of course, then knocks on to risks of having less income than you need. So it matters for well-being, personal satisfaction, and also societally for contributions that we can make. The shocking point I'd like you to grip, first of all, is we have the worst healthy life expectancy in Europe. And that is a shocking fact that ought to drive us to address change. If we then look on to the next slide about why it is that we're so, well, where we're so ill and why. Recent data analysis done by Rupert Dunbar-Rees for the NHS found that on average, women in Britain, women in England get their first serious long-term illness on average when they are only 55. Poor get it much earlier. In the poorest areas, people live in ill health for 20 years longer than the richest. And so you've got the preventable poor health, widespread and with high economic and fiscal costs. COVID has exposed these risks even more. Next slide, if we could, Lily. Prior ill health and age are the two key drivers of mortality. And if we ask the question, which we must ask, why has Britain had one of the highest COVID death rates? One of the obvious answers is because we have got, particularly for a well-developed country, one of the poorest basic health conditions of our society. We tend to celebrate the NHS as we should, and their science and technology competence. We do not focus enough on the fact that we have an unhealthy population and the consequences of that. You know the data, I won't go through it. Well, the highest obesity rates in Europe, and obesity has a very high increased risk of death from COVID, chronic respiratory problems, a whole range of other long-term conditions which degrade life and also increase the risks of illness or death from COVID or other pandemics. That's the general position. If you go look next at where it bites most, and following on from Michael Marmot's talk, poor people have a higher risk of death pro rata than the well-off. Why? Because they have much higher rates of prior illness, poor health. If you look at what's called the social gradient on ill health in Britain compared to other countries, in the poorest areas, 24% of people are in poor health compared to in the richest. That isn't a fact of life. Other countries, New Zealand, Greece, and France, have a much narrower gap between the poor health across the social spectrum. So there's something going seriously wrong with the health of our country generally, and with the health gradient in our society. Looking though forward, we should all suddenly rejoice because we have got the US Cavalry potentially coming. The Prime Minister declared in the manifesto a great commitment for everybody to have 5 extra years of healthy, independent life within 15 years, and to narrow the gap between the richest and the poorest. I think that is a great manifesto commitment. It's exactly what you want to see from a national government, and the recognition that these are big changes and that they require time. Only one slight small problem: we've got a great goal and no plan in sight to do much about it. Because of that, Damien Green, Tina Woods and I, with a whole range of very talented organizations, including ILC, looked at what would we need to do as a nation to achieve that goal. Because we felt if government hadn't produced a white paper, why shouldn't we do so? And we set it out in that. I won't go into lots of detail, but the first point I would make is we should recognize it's possible. It's not mission impossible. It's possible. We've done such things before. If you look at the reduction in smoking rates, or the reduction in stroke, or the fact that the well-off in our society already live so healthy, longer lives, we know it's possible. And when we talked to Chris Whitty, CMO, he gave that great quote from WHO: we could prevent 75% of new cases of heart disease, stroke, and type 2 diabetes, and 40% of cancers if we cut radically smoking, unhealthy diet, harmful consumption, and alcohol and insufficient physical activity. We know also, of course, we have to address the poor economic, physical, and social environments as well. But just looking at some of those immediate risk factors, addressing those as one of our first steps would make an enormous difference. So question, what's the agenda for change by public policy and society more widely to make that improvement in health in our society, which we, I think, now recognize from COVID, just desperately need to do. As you'd expect, it requires leadership by 4 partners: national government, localities, the NHS, business and research. And I'll touch on each of those. It needs perhaps above all a recognition you've got to stick with it and be resolute about it for 15 or 20 years. Looking first at national level leadership, there are a number of things that only central government can do, however wide the activity levels that we require are across society. I think only government can make it a national ambition and mobilize, allocate the finance and give the right central leadership. Clearly, we would expect nothing new here. WHO have been saying it for decades. You have to have a health in all policies approach by central government. You have to have healthy transport. You have to have healthy foodstuffs. You have to make tax and welfare policies think about how they can contribute towards health. They do not at present. The Treasury tends to think it has no policy responsibility for the health consequences of its fiscal policies, and that is not responsible. You have to make healthy choices, the easy ones and the cheaper ones. Food, it should be easy and cheapest to choose healthy food options rather than expensive. And there are plenty of ways that government, by regulation and taxation, could make that happen. And above all, nationally, you have to build a strategy in a collective way with partners and not just see it as some top-down central government mission. You have also, though, at national level, and this is where it gets difficult, to do what the evidence says what works and prepared to do so and throw out of the window some of the political shibboleths that have impeded this. So being willing to actually regulate and tax harmful substances, as we have done with smoking across the segment, and not be so ultra-libertarians as central government in the past has sometimes been. But localities are vital as well. And you can't do this top down. You have to recognize that localities have themselves to own their need to own in the improvement of their society. We have seen great examples of this by Wigan and elsewhere, where they have had conversations with the localities about how we want to make our society healthier, because that's better for our well-being, our economy, and our society more generally. So recognizing this and developing community-based commitments to improve local health is a fundamental part of a longer-term strategy. But also central government, of course, needs to affirm and recognize the importance of localities and not behave in perhaps quite the way, with hindsight, we think they behaved on some of COVID, which tended to ignore localities until they realized that they were essential partners. Looking next at the NHS, and we were quite tough in our report, the NHS spends less than 5% of its budget on prevention of all types, and that is hopeless. We said that that should be raised progressively over the next 15 years, over the next 10 to 15 years, to about 15% of its budget. Why? Because they are incredibly well placed to make a major contribution. They are very well placed to improve the detection and the prevention of early risks, and to try to shift behaviors and lifestyles, or to bring medical interventions that support those, so that more people are able to live for longer in good health or good enough health. Clinicians at points of contact are very influential to nudge people to recognize that they've got to do something about their health. I haven't got time to tell you a good joke, but another time I'll tell you a good joke about my JP. So the NHS owning this agenda, and they've never really made health prevention a central mission, and they will need to do so, if only for self-interest, to do something to reduce the tidal wave of demand that is coming towards them. Next, business. Business can be either the problem or the solution. By this I mean, there are some sectors of business, and let's talk bluntly because nobody's listening, which make seriously harmful contributions to the health of our society. You've only got to think about the tobacco industry, the alcohol industry, or some aspects of the food industry to realize these are sectors that are harming health. We have recently formed a business for health coalition, which is trying to coalesce those businesses that recognize that they, as businesses, need a healthy nation. We can't afford another pandemic like this, because they've recognized that an unhealthy nation, pandemics, damage business and the economy. So the Coalition for Health will be seeking to get businesses who are committed to this goal working together to promote improve health of our society, because businesses can make a great contribution. One of the ways we'll do this is to trying to build an index so that we can measure the contribution for good or ill of sectors or individual businesses to the health, so that in time this can become a metric that investors can use if they wish, like we are doing increasingly with climate change, to choose sectors and businesses that will contribute more to the health of the nation. Last, my apologies for the clock. Last, research, technology and data. I won't talk a lot about this because Les is going to be able to talk on this. There's the great contributions potentially from research, technology and data, both to stimulate, those of us who wear Fitbits know how these are quite useful mechanisms for increasing activity rates. Or there's a great social divide problem on that, of course, but no time for that. We also think that AI, big data, and tech have great contributions. But the danger is to think that we can sit back and just leave it all to miracle medical cures or technical solutions. So it's getting a balanced approach to recognize they've got vital contributions, but don't think it's only those. So will anything happen? Well, we've been, on my last slide now, we've been seeking to talk with Matt Hancock and with Chris Whitty and others across government about this, but they've been a bit busy in recent months. We will be having face-to-face conversations with them. And we're basically saying, you've got to own this manifesto commitment. Because as Matt Hancock says, it can't be right morally. We've got such an enormous gap in healthy longevity across our society. And we now know, as a consequence of COVID, how serious it is for our society and how serious it is for our economy and for businesses as well. So the evidence is clear from COVID. We cannot carry on as we have been in the past. And it ought to be a clarion call to government to face up to owning this great manifesto commitment they have made. And there are plenty of us who will work with them to try to make that happen. There we go, Lily, over to you.
Thank you, Geoff, so much. And I think very well fit into those 10 minutes on a really comprehensive strategy of where we need to be going. And I think you're absolutely right in saying it's not a single actor, so it's not just government, but also it's not just a single sector. So we're not just looking at health, but actually all the sort of wider determinants that influence our health and well-being. Just mentioning on the localities point, in Michael Marmot's presentation, he mentioned that, the greater the deprivation in local areas, the greater the need for public expenditure and the greater the cut in spending. So I think there's much, much more we could be doing in local areas as well as central government. And clearly that actually, when we're looking at how healthy life expectancy has developed here in the UK, we often hear people saying, well, maybe there's just a limit. But if we look internationally, clearly there's more we could be doing. So if we're comparing ourselves to other countries in Europe or more broadly. And I think this is where I'd love to bring in Francesca Colombo, who's joined us from OECD, to speak a bit about, what can we learn from other countries potentially, but also how can we work together better? During COVID-19, I think we've seen great initiatives and great progress in countries working together to prevent the spread of the virus. What can we learn from that? Can we make sure that some of this momentum stays up so that it's not a one-time thing, but we're actually doing this more strategically going forward? So Francesca is the head of the health division at the OECD, which aims at providing internationally comparable data on health systems and applying economic analysis to health policies. advising policymakers, stakeholders, and citizens on how to respond to demands for more and better healthcare and make health systems more people-centered. So Francesca heads up the entire health division. Obviously, she's had a lot of responsibility recently on COVID-19, on making health systems more resilient, and measuring health outcomes, activities, and inputs. So Francesca, we're absolutely delighted to have you joining today, and over to you.
Thank you very much. Thank you also to David for laying out so well the grounds. I think many of the points that you made, David, resonates very much with the work that we are doing. So I could not agree more. And what I'm going to be talking about builds on what you have been saying. We'll be making 3 main points in this in the area of really like the international cooperations domain and what can we learn. And the first point is really about the fact that even more than ever with this crisis, it's quite clear how our economies, our societies, our health systems are very much interconnected. And so addressing obviously COVID-19, but I would argue that also addressing wider challenges that we are presented in the health sector requires international cooperation and deep learning across each other. And that's my first point. Secondly, I will be addressing some of the things that to me are deep-rooted problems in the aged care sector and long-term care sectors, which have been made even more stark by the COVID-19 crisis. And that goes back to some of the points that David has mentioned very much. And thirdly, what can international cooperation do? So I'll be quite quick on all of those. I mean, the first thing, it's a very simple point. It's clear that our economies, our societies, our health systems are very much interconnected. This is not just something that we see because there is an infectious disease that by definition, obviously, does not have any boundaries. You know, we are all vulnerable to an infectious disease. It does not stop at border, of course. But even if we look at the way our health systems are interconnected, yes, there is a lot of policy making which happens at national level, but supply chains in the health sector are very deeply interconnected. And you know, their mobility of workers and health professionals and so forth. There's the issues of vaccines and how do we create innovations also for you know, new goods and services and that are important, and that's something which is really a cross-border issue very much. And so addressing those major issues that affect elderly populations, more broadly, obviously the health of populations require really robust international collaborations. And that's something that OECD has been very much at the forefront from the beginning, really trying to call for the need for a concerted international action and efforts to both buffer the health, the economic shocks, but even the labor market shocks that COVID-19 brought about, but also to rethink about how do we rebuild better our economy, societies, and health systems, you know, learning from the crisis, but also learning that some deeply rooted issues could have been addressed better before the crisis itself. And so this brings me to the second point, which is really related to what I think are some deeply rooted problems in the aged care sector and long-term care sector, which have been manifested quite starkly by the COVID-19 crisis. I mean, obviously, we know that the crisis hits particularly the older populations, many, especially of those living in long-term care settings, but not only, we know 90% of the deaths across OECD countries were among the over 60, and over, you know, across the OECD countries as well, about half of those deaths has happened in long-term care facilities and nursing homes. So it really shows how there is a particular vulnerability of the sectors, which highlights some pre-existing weaknesses that must be addressed from policy, from investments and action. One, obviously, is the issues of inequalities, which have been highlighted. You know, we know that people who have more chronic conditions, who are poorest, have been particularly hit hard by the crisis, but also more generally are at highest risk. Elderly people who are less educated are actually twice as likely to report needing long-term care services than those who are better educated. So there is a starking social gradients of inequalities that actually creates over the life course of individuals. It's not just a matter of addressing inequalities in old age, it's really a matter of addressing inequalities as they build through the life course of individuals. And so what really the crisis has shown is the importance of building not just resilient health system, resilient long-term care system, but also resilient populations, by really making sure that risk factors are addressed. There are also structural problems in the sector, long-term care sector, and aged care sector itself, with underinvestments in staffing, in safety protocols, poor coordination with the healthcare sectors. They're considered really as separate things. There's been even a failure to see that a crisis that was hitting very much the elderly care sector did require obviously actions and immediate action in that sector. So it's immediately that the attention was to hospitals and what happened in acute care hospitals. But for example, personal protective equipment were not prioritized early on in the crisis in the long-term care sector. So, a failure to really see that there is a big shock which is affecting the elderly care sector, and we're not really addressing or directing the solutions to that sector. That's something that, that requires attention. But also there is a need to think about the needs of the populations as people age, becoming more complex. More and more dependent people have multiple chronic conditions, in addition to having dementia. And so, even thinking about the type of skills for the health professionals, for the workers, the type of safety practices and protocols that we have in the long-term care sector require really, more comprehensive solutions. So that's my second point. There are deeply rooted issues in the health and long-term care sectors about staffing, about protection, safety practices and protocols, about inequalities. Have been magnified by COVID-19, but they do need to be addressed in the root causes as well. And the third point for me is obviously the international cooperation can play an important role. If we look, for example, at what happens, in a few years ago, when it was actually the UK that put on the agenda of the G7, at the time it was a G8, in 2013, if I'm not wrong, it puts dementia very much at the forefront of the policy discussion. That then triggered a series of international high-level events in 4 different G7 countries, and really put as very much a high at the political level, at the highest political level on the agenda, these issues of dementias. That Japan, in the context of the G20 that recently had the presidency, they put universal health coverage in the context of aging societies at the very center. Obviously, WHO as the decade of healthy aging, and the OECD has done a huge amount of work on issues related to aging unequally, the long-term care sectors, and so forth. So I think there is a role, even in terms of putting much high on the agenda, problems which are particularly important. The other, obviously, very important role of international cooperation is in terms of learning opportunities, sharing statistics, sharing useful practices, just looking at what the neighbor is doing that might be helpful to understand that that's something, obviously, that is a little bit the bread and butter of the work that we do at OECD. But another value of the things that we do at the OECD is also to bring to the fore the economic perspective, not just the health dividends from healthy aging, but also the economic dividends. And again, it was mentioned very much by David at the beginning. there are economic implications of population aging for, economic growth, or the lack of opportunities for improving economic growth from unhealthy aging, for example, and also in terms of possible raising healthcare costs. And so successful healthy aging really has important dividends, not just from the health of populations, but also for economies and societies. And this has been very much put again at the forefront of the discussion of the G20, which is an economic group of countries. It's a group of countries that really has very much of an economic focus, looking also at issues related to the benefits that might come from more healthy living, more healthy way of feeding, of avoiding obesity, that we know brings not just dividends in terms of life expectancy, but also really in terms of labor market productivity and growth. So I think I'll probably stop in there. There is clearly a need for looking beyond what happens in countries to continue to make that political case, to make the economic case, and also to learn from useful practices within the health sector and across other sectors that are very much interconnected to the health and long-term care sectors. Thank you very much.
Thank you so much, Francesca. And I should say, actually, I think both you and Jeff have been quite positive, surprisingly, sort of in this sort of very difficult time around, actually, this is achievable, we can be doing more. And I think similarly during COVID-19, the sort of lessons we've learned of how, well, actually, if countries want to, they can be working together, and they can share data, they can share learning, looking at things like the sort of COVID app that's, started one country's sort of been taken over in others. I think the points you raised around sort of long-term care are particularly pertinent, I think, in the UK as well. I mean, we've been waiting for a social care strategy or green paper for, well, I don't quite know how many years now. And I think the question around actually, the lack of attention that's been paid to it. So here in the UK as well, it took weeks for people to notice that, oh, actually, we should probably bring some PPE into care homes. We should probably start counting data there as well. And I was wondering, actually, Francesca, because I think you mentioned a couple of initiatives that are going on. So, for example, the Decade of Healthy Aging. There's sort of focus on universal health coverage and aging as well at the G20 in Japan. Do you think there is more potential? Do you think there would be an appetite for, a really sort of leading out of this sort of beyond the pandemic as well, an actual concerted sort of aging society strategy? Do you think people are ready for that, or is that not urgent enough at the moment?
Look, it's both in a way. I think there is a realization of the critical needs, but it is true that the international attention is also so much focused on the pandemic preparedness itself, that there is a risk of forgetting that the people who were most affected were precisely the people who are older, and within those who are more fragile, those with pre-existing working conditions and so forth. So the way international work goes is that it goes also through phases. As I mentioned, the G7, then G8 addressed dementia very much, and then it followed with a series, a nice series of high-level international events, and then it went a little bit more, I would not say in the neglect, but it got a little bit less attention, and other things came to the fore. Antimicrobial resistance, huge threat, to be frank. It's a huge threat for societies. How countries and health systems are not ready to a shock such as that brought by the pandemic. Now it's very much at the center of attention. So I think there is an opportunity there, but there is a risk that we forget about how interconnected all these things are, and how we have one of the reasons why we suffer so much from the current crisis is because of those, as I mentioned, deeply rooted structural problems in the health and long-term care sectors, which should have been addressed before. So we need to keep on making the case. I think that's the point. And making the case means making the case in terms of the health lives, but also in terms of the economic case, because that's what speaks to prime ministers. That speaks a lot to, fora like the G20. That there is not just an issue of, it's important for the health of people or even a human rights issue. There is also an strong economic rationale.
Great, thank you so much. And I've just been made aware that we are sort of running tight for time, so I will move straight on to our next speaker, Professor Les Mayhew, who's one of our colleagues here at ILC. He's recently joined as Head of Global Research, but has worked with us also for many, many years as an advisor. He's part-time Professor of Statistics at the Business School, which was formerly the Cass Business School, and is also Managing Director of Mayhew Harper Associates Limited. His previous experience is very vast and spans 20 years in the Department of Health and Social Security, the Department of Social Security, the Treasury, and the ONS, amongst others, where he was a director. So great to have you here. And we've talked a little bit and touched on sort of questions around how countries can work together better on data. Clearly, even on a national level, we can only really get these sort of preventative interventions right when we know who needs them, where they're needed, and how they're needed. And I know you don't want me to call it tech, so thinking sort of more on the role of sort of big data. What do you think the potential for it is? What can we be learning in the next sort of years to come, both in the response to the COVID pandemic and also beyond? And I know you'll be sharing some work you recently did, and the blog is on our website as well, on big data and diabetes.
Yeah, I'm fully on board with the prevention question. I've been looking at it for years, and one of the big struggles is trying to put a value on it so that you can convince politicians, decision makers, that it's the way to go. They like to see results in coming back in different ways, and there are lots of ways of doing that. Jeff mentioned getting more people back to work so they can work for longer, but another one is the reducing the burden on the health service. So when I started looking at this, I was invited to do this piece of work in East London, and I'll come to that in a minute, but just let me give you a tiny bit of background here. I think that a lot of public health's achievements in the prevention area only become apparent with the passage of time, and we see that with improvements in housing and wider determinants of health like education. Seems to me, though, that what COVID has done is it showed that the challenges are still with us. Those challenges that we thought we had defeated, like infectious diseases, are obviously still around, and they've come back big time to impact us. Now, how to allocate scarce resources in this area is a big issue. It reminds me a little bit of the advertising manager who says, I know that 50% of my expenditure on advertising is effective. The problem is I don't know which 50%. And I think this dilemma is repeated up and down the country in public health departments and by health service commissioners. And what they're delivering is what Sophie Howe called this morning a national illness service rather than a national prevention service, which I think we ought to really think about seriously. So is it better to spend money on smoking cessation, dietary advice, or subsidising gym membership, or should we be spending more money on housing, schools and air quality? We don't really have a comprehensive cost-benefit Bible, as do other branches of government, and so we tend to deal with everything on a case-by-case basis and reinventing the wheel. So the slide you see in front of you is about a case study on diabetes. I'll give you some of the reasoning behind it. Diabetes is a lifelong condition that can affect your everyday life and can also increase the likelihood of more serious problems, but it's also essentially preventable. And we also know it's a predisposing long-term condition for COVID complications as well. So it's very, very relevant at the moment. Now, this study was based on 230,000 adults aged 20 to 64 in East London, and we found that 5% of residents, after looking at medical records, had been diagnosed with diabetes. But that varied enormously according to the risk factors in each individual. So for example, we found that 1,500 residents who were hypertensive, obese, current or ex-smokers and male, 41% of those were diabetic compared with the 5% average in the general population. So what, you might say? Well, we then looked at their secondary care records, as this chart shows. Now, the left column, I'll go through it fairly briefly. The left column shows that those with all risk factors were 5 times more likely to experience hospital spells compared with those with none of those risk factors. You see the risk factors in the legend to the right of the chart. Now, that column to the right shows the incremental cost per risk factor of a person who is diabetic, of a person that has one of those risk factors. So a person who is diabetic costs the NHS an extra £469 a year. If they're obese, it's £225. And if a current or ex-smoker, it's another £237. If they're hypertensive, then it's £382. So all of these risk factors, the costs of them are additive. So someone with all 4 risk factors costs £1,468 compared with £155 for someone with none of them. Now, it turns out really interestingly that these factors statistically explain 92% of the variance of costs in this demographic segment. So for the whole area where these conditions occur, secondary care costs £78 million a year for this population. Now this falls to 55 million if none of these risk factors were present in the population, theoretically saving some £23 million a year. Now I would suggest this is probably a conservative estimate, since a healthier population would be expected to use the same services less than previously. My point is that by putting a value on prevention, we can do lots of things that we couldn't do before. We can use the evidence to show showing a difference to inspire and engage both decision makers and policy makers, who hopefully would react by making much better, much more focused decisions than they previously were able to do. And I think it would also open up access. By opening up access to prevention, we can reduce health inequalities, looking at this in a broader context. And thirdly, if we can harness it and turn it into fun, I think we could also empower individuals with this kind of information. Now, other case studies based on this larger project that we undertook show clearly the impact of socioeconomic inequalities as well as clinical risk factors. This means we can also target preventative actions on localities at greatest risk using just a few basic criteria. So to conclude, I use the term big data because it concentrates on universally available local administrative data sources. Now, there are literally millions of pieces of data out there that you can use, and with the right analytics, turn it into something useful. Now, you simply can't get this granularity in official data sources, as we've seen time and again with the COVID pandemic. My hope, therefore, is that districts up and down the areas up and down the country, and providers will collaborate to develop this capacity so as to make a difference. Now, there are signs of this occurring in lots of areas. So on that slightly more positive note, I'll conclude.
Thank you, Les. And I think really pertinent to think both about how it can enable us to make a better case for prevention and be a tool alongside the other sort of cases that we can make for why we should be living healthier, and also to understand essentially where we put our 50% of the advertising budget that works, and I guess as well to think about, very often I think we think about tech as the sort of silver bullet in this whole kind of question. I think it really does work as an enabler to either see where or how, but clearly it's not the magic bullet. And one example we had when we were doing our prevention program over the last year, when we were speaking to some healthcare practitioners in the US, was that there's an example there of essentially where they could, in the US, where they could see sort of to a block level, essentially where people were experiencing hypertension. And then that's where you know, that's very much where the human element comes in, where people who know the context, who know the community come in. But it's the enabler to see, oh, actually, you know, where do we need to be putting this in. Thank you so much. And just to mention to all attendees, I think we will be running a few minutes over just to make sure we get to all our speakers today. And we have got a lunch break afterwards, so you won't be missing any of the other sessions. So I'll move straight on to Debbie, our final but definitely not least speaker. So Debbie Woods is Head of Medical for General Medicines at Sanofi UK. She originally qualified as a registered nurse in the 80s and specialised in neurological intensive care and trauma medicine. And she's been a passionate advocate for patient involvement ever since. And in her current role, Debbie's accountable for delivering a patient-centric medical strategy to support the general medicines portfolio at Sanofi UK. Really delighted to have you here. And sort of, you know, I think it will be sort of leading on very much from the other points that have been made here. You know, where do we go now? The pandemic has really shone a light on some problems that have been there before. They're not new. They've been there before, but they might also continue. And especially in the context of an aging society, if we're thinking about multiple conditions as well, you know, it's likely that we are going to see a growth in those conditions. So, you know, where would you see the sort of way forward, and what are some of the sort of key strategies? Yeah,
Thank you. Thank you, Lily. And I think it's a very pertinent question about the way forward. But while reflecting on the past as well. And when I was preparing for today's talk, I was recalling my first day when she was a student nurse. And as part of that first day, one of the ward sisters gave a talk on what it meant to be a nurse. And after nearly 40 years, her opening words have very much stayed with me. And she said that every word, every action, every gesture, no matter how small, will make a difference. So make those words, actions and gestures make a positive difference. And I think that is something I've carried with me through my career in the NHS to my career in Sanofi. But that was 38 years ago. And now there is a need for all of us to reimagine how people can be helped to live a longer life in good health. Not in a way which relies solely on the NHS, but where we are all, individuals, businesses, governments and charities, play our part. And I think the other speakers really brought that out very clearly. As an organisation, Sanofi is very determined to lead the way in prevention. And we work with the NHS. We provide vaccines to help the preventive spread of disease, and medicines for the chronic conditions such as diabetes, which can prevent symptoms worsening or complications arising. And as an employer, Sanofi is absolutely committed to support its employees to lead healthier, happier lives, and wants to inspire other employers to support their workforce to do the same. So very much of the opinion that what we say must start with us in-house. So as Geoffrey pointed out, prevention initiatives can and have had success where we all work together, reduction in smoking rates being the most obvious, brought about by governments banning tobacco, advertising the smoking in public places, by pharmaceutical companies investing in the quit smoking aids, and the NHS making them available, and by businesses selling tobacco responsibly, as well as individuals choosing to quit. But there is a long way to go. Now, flu vaccination is something that's probably one of the most effective interventions we have to reduce pressure on the health and social care system during the winter. And obviously now within the current pandemic, vaccination is even more brought to the fore. But also preventing disease complications. I think it'd be naive to think that we can prevent disease. That is a naive thing to do, but the complications that we can prevent through better self-care and earlier diagnosis and intervention will also help ease that burden on our NHS. And as employers, we can and we should do more to prevent ill health. People in jobs where they feel stressed or unfulfilled are twice as likely to report ill health. So for every £1 on average that an employer spends on supporting the mental well-being of their employees, they get £5 back in reduced staff turnover, sickness absence, and employees working while unwell. So as a company, Sanofi are determined to lead the way in preventative healthcare, both with our treatments and solutions, and in looking after the well-being of our employees and supporting them to live longer and healthier lives. And it is easy to talk about medicines, but actually pharmaceutical companies, Sanofi included, are much broader. For instance, the diagnostic testing, allowing early disease management, as well as the interventions that encourage self-care. And as mentioned, Sanofi really did welcome the publication of the government's green paper on advancing our health. But as always, we need to support and the government's focus on prevention and helping to make a case for appropriate resources and professional training. By keeping people healthy, by providing the right support in the right place and treating health problems quickly. And moreover, committing to that workplace, good health and well-being. And Sanofi call for governments to invest in public health budget to support the availability of new treatment technologies, not just in England, but in the devolved independent nations as well. And also the research to qualify appropriate percentage of GDP per year to be spent on prevention policies across government, including on the implementation of prevention commitments within the long-term plan. So how do we move forward and really addressing the health inequalities, self-care, and that improved secondary prevention become all important? And I'm going to slightly cut short my talk because I am very aware of time. But what I do want to say that there are a number of ways in which secondary prevention can be improved. For example, the innovative monitoring technologies that have been mentioned, better patient education, virtual clinics, medicines optimization and adherence. And there is already emphasis on new models of care. For example, the primary care networks that are doing more to prevent ill health and diagnose conditions earlier. So I really want to finish by saying helping people to live healthy lives is a shared responsibility. And to go back to what that ward sister said, every word, every action, every gesture that we make will make a difference. And I believe that working together, we can actually make a positive difference. So thank you very much for the opportunity.
Thank you so much, Debbie, and actually to all of our brilliant speakers today. I feel really bad actually to be cutting things short and finishing the session here. Just to mention, by the way, that if you do have any questions to anyone, you can use the chat function on the platform as well to ask any questions, or to email them through to us as well. And I think we can continue this dialogue. I think it's been really, really interesting. Thanks all so much. And thank you also to Sanofi. I think we've seen that, actually it's sort of for all of us to come together, everyone plays a little part, and there's much that we can learn from each other. But actually there's some really viable things that we can be doing as well. And I think a commitment to prevention spend is a really important way forward to make sure that we're actually not that sort of reactive national illness service, but a sort of well-being service. I just wanted to flag very quickly that at ILC we are sort of moving on from our original Prevention in an Aging World program that looked at the sort of why for prevention, which I think we've covered lots of here today as well. We have launched our second stage, which is looking at how we can deliver that. And I won't be going through any of these slides particularly, but if you would like to get involved, there's some contact details here and you can find out more on our website as well. So thanks again to all of you, and have a nice rest of the day. We will now have a lunch break. So feel free to have a bit of a break from your laptops and screens, or if you want to, you can also join our networking room that's open all day. Thank you.
Thank you, Lily. Thank you. Bye, Jeff.
Bye, Les. Bye, Lily. Bye, Francesca.
Bye.
Bye, Debbie.
Bye-bye.
Bye, everybody.